Thank you. Please sit here, because now I'm inviting all the speakers from this second part of the session to join us here around the table, and we will be glad to receive some comments and questions from the audience. So please, Larry, Stephen, Halloran, Nirio. Did I forget somebody? No, I don't think so.
Rugile.
Yes, Rugile, even. Just till everybody sits down, I have two announcements to make. People were asking about the presentations. They will be available at the EPAAC website, so please visit when you come home if you want to see the presentations. And the second invitation, from today afternoon till Saturday, we have the meeting of European Cancer Leagues at the Institute of Oncology, Ljubljana. This afternoon at 4 starts the workshop on cancer screening. So if somebody doesn't have to do anything here in Ljubljana in the afternoon, kindly invited to join us in Building C of the Institute of Oncology at Zaloška cesta. Thank you very much. So now, is there any question or a comment from the audience about what we heard this afternoon about the implementation and organization of cancer screening programs? Perhaps that till you warm up, I would like to ask Larry. We were all the time speaking just, I think, about screening for 3 cancer sites: cervix, breast, and colorectal. I wonder whether there is anything new and whether the Commission will prepare any recommendations about any other cancer site. I must say, from our experience, we face quite an epidemic of prostate cancer because of such huge use of PSA testing in a diagnostic settings. So will anybody give any recommendation to countries about this testing?
Well, in fact, during the ESSM course, we also looked at screening for other cancers. And we've also been looking at this in other areas. From what I can say now is that I don't see the evidence on the table yet to recommend prostate cancer screening or lung cancer screening. There is now in the United States an official proposal for consideration for screening high-risk groups for lung cancer. But I don't see the evidence on the table today. Now, we have the 10-year anniversary of the Council recommendation. I wouldn't be surprised at the 20-year anniversary that we have found the solution. But today, I don't see the evidence on the table that can say we can achieve a balance between harm and benefit, which is appropriate. I would just stay tuned in to the discussion.
Thank you. So, yes, please, can you pass the microphone?
Thank you. My name is Milena Sant from the National Cancer Institute in Milano. I have a question for Dr. Segnan, but also for regarding the study on Mediterranean countries. So my question is, has been done an evaluation of the priority needs in these countries with regard to breast cancer screening? Because maybe the main problem in these countries is late diagnosis, but late diagnosis of symptomatic cancer. So the main priority could be to improve the care of cancer and the cure of cancer. So the question is there any evaluation, and also on the way, and as Dr. Thornberg pointed out, the way of evaluation of the effect in terms of reduction of mortality, but also for breast cancer, but also in terms of effectiveness, for instance, in terms of downstaging of symptomatic cancer. Thank you.
Yes, you can read in the report this evaluation about the priorities, not only for breast cancer, but also for colorectal cancer and so on. So there is first a huge difference in a Mediterranean country of the risk for breast cancer. And this is related to lifestyles. Some lifestyles can be maintained. Some other, perhaps it's better not modify healthy lifestyles. And so this is one message. If a cancer like breast or colorectal is low in incidence, perhaps it is important to try to maintain this risk low. And this is the first message. The second message is screening without the appropriate treatment is absolutely meaningless. And so if there are not resources for treatment, this is something that is a priority. Otherwise, any potential benefit of screening would be wasted. And the third point is downstaging, breast awareness, colorectal cancer awareness, and so on. And this is the third topic that we discuss in our report. So putting all this thing together, in many countries, breast cancer screening or colorectal cancer screening, for these reasons, is not always a priority. Other diseases, other chronic diseases, not only chronic diseases, are in this country priority, and so you have to make a decision according to this situation.
Yes, please.
My name is Dr. Simon from Hungary, and I want to ask Professor Halloran, yes. It was a wonderful presentation, and I am not sure. I had seen in the diapositive how you mentioned how the Prime Minister took part in the propagation of the bowel screening. How could you convince it?
Could I ask you to repeat the question? I didn't catch all of the question.
How you mentioned how the Prime Minister took part in the propagation of the bowel screening. How could you convince? I want to learn the methods.
I wish I knew the secret to that one.
It's very secret.
I have to tell you, it caught us all by surprise.
Yes.
The announcement occurred on a Sunday morning in this political program, and I know that Julieta Patnick, who leads all of the all of the screening programs in the UK, she only heard about it on the Saturday morning. I heard about it on the Sunday morning. And quite frankly, in this particular situation, we would have liked to have had a couple more years to digest the research that Wendy Atkin had done, and allow us to determine exactly what would be the preferred age. So we've gone to 55. Nobody turns away £60 million when it can be spent on screening, but maybe it could have been announced in a more effective manner. But perhaps your Prime Minister might like to have a word with David Cameron, and he can sort it out.
Is it possible to refer back to one of our previous speakers, Ana Molina, who put forward the evidence that she had collected for inequalities for screening in different socioeconomic backgrounds? Can I suggest that the evidence that she produced was really quite strong, and that rather than moving to more studies, in the next CANCOM, that we start looking at strategies, how to approach these minorities, because we've known about this for a very long time, but we haven't had enough, maybe for doing official programs, evidence. it is a huge concern, especially in colorectal cancer, with sensitivities towards different minorities. I was discussing this earlier with Rosemary, and she was saying that in France, they make sure that there are more women radiologists and for breast cancer, so that women from backgrounds where they don't feel comfortable to be examined by a man will have women. I think we strongly need to get a strategy for this, and I would be really pleased if CANCOM could move this forward. Thank you.
Thank you very much. Has anybody anything to add?
Anna, would you like to add something?
Well, I'm sure that the strategies are certainly needed, especially also in the Mediterranean countries where the way of life is even more different than in minorities. So I'm sure that the next step would be really strategy for different population groups. Thank you very much. So
Anna was going to answer.
Only to say that, in fact, we are going to participate in the work package 4 of the new CANCON, and we are going to try to integrate in all the chapters of the guide the social inequalities perspective.
thank you. Any other questions, remarks?
Works? Yeah. Thank you. I would like to ask maybe organizers for this European School of Screening Management, what are the chances for continuation of this school? I was participant of this school and it's really excellent, and I think that continuation of it would be good support to diminish, let's say, the differences in quality assurance in different countries, and support to, let's say, assure quality control and better organization and management in different countries which would need this. Thank you.
Thank you very much, Josica. I think from my perspective it is really obvious that this activity should continue, and this intensive training course was the smallest possible project we could imagine to set the ball rolling, so to speak. So in the senior management team we will be looking now for a strategy now to apply for additional funding. And we would really like to encourage also DG Sanko and possibly other Director Generals to think about the value of developing this resource. I think we saw there's so much potential here to learn from each other and to promote this type of exchange. But what we also see is that you know, the number of people who have that experience is quite limited. So if we don't link these centers and enable them to collaborate in research and translational you know, application of these tools, if we're not able to give the new generation of people who are trying to implement screening an opportunity to specialize, then I think we're going to miss a goal. So yes, we're very interested in continuing, and we'll be looking now for opportunities for funding for that.
Thank you very much. Any additional? Yes, Sven, please.
Yeah, I have a comment to the Hungarian gentleman. When approaching politicians, we need to learn what's the role of the politicians, and it's usually to make priorities when it comes to financing different things. So the best way for you, I would say, would be to collect your colleagues and agree on what you would like them to do, and also to help the politicians with the priorities, because that's their problem if they have to make all the priorities themselves. But if you could help them, I'm sure you will succeed.
They are only promises and have to do something. They forgot what they promised. This is my experience.
Yes, last question, please.
The European Cancer Patient Coalition. I wonder whether you have evidence that in all countries for the colorectal screening has been used the procedure indicated by the recent approval guidelines.
But I think that not only for colorectal cancer screening, but also for breast and cervical cancer screening, the implementation of a quality assurance system is a continuous process. And so when you look at a different system for quality assurance, you can find some heterogeneity that is on one side what is positive in order to modify, to improve the system. On the other side, in many situations, is a sign of not adequate quality. As far as colorectal cancer screening, we have, let's say, a situation for colorectal cancer screening for which there is a well-organized, well-structured regional or national program in some countries, UK, Spain, Italy, and in other situations, the screening program is something in the implementation phase. And so the dissemination of colorectal cancer screening is not so strong yet as it should be, given that colorectal cancer screening is a very cost-effective screening for cancer. It's the first screening that permits to save money. And this is not true for breast cancer and cervical cancer. So if you screen, given that you prevent cancer, you can save money for treatment and so on and so yet. So the quality assurance is a fundamental aspect, and in this organized program, the system of quality assurance are effective, and you can see the publication and the annual report from these countries. Certainly the dissemination is still not so important as it should be.
Thank you very much. Larry has additional comment?
Yes, perhaps just a brief comment. We are now in the process of updating the report on implementation of screening in the EU. And what we already know is that quite a few more countries in the EU have embarked on the process of transforming their opportunistic programs to a population-based approach. For a recent example is the screening law that was adopted in Germany in April of this year, setting a deadline to change the colorectal cancer screening program to the population-based approach, which is recommended by the Council and which is necessary to begin to implement the quality assurance in a more effective way. But the point I would like to make is that these guidelines are rather complex, and the things one needs to do and to document are also rather complex. And we have a situation in Europe where, even though cancer registration is far from perfect, it is much more highly developed than screening registration. So what we think needs to be a focus of future activities, perhaps pushed forward and catalyzed by this European Schools of Screening Management, is to bring the cancer registration up to the same level of the screening, to bring the screening registration up to the same level, so that the data in screening and the data in the cancer registration can be better linked. So this is a high priority, because it's not just enough to see, well, is the approach going in the right direction? You really have to document and evaluate everything.
If I can add something, I think is a very important approach and example to follow what is done in Finland, because the implementation of colorectal cancer screening is such that the evaluation of the impact as far as mortality and the incidence is possible. And this is in a screening service program. So the randomization by birth cohort and so on, and the gradual introduction of the screening for colorectal cancer is something that in country where there is this project of implementing colorectal cancer screening should be followed.
I hear that Michelle Coleman has, and this is really the last. Thank you very much.
Maya, thank you very much. Very briefly, Larry, I really liked your presentation as ever. Would you consider endorsing the possibility that the program for screening registration that you just described be integrated from the outset with cancer registration? Because where cancer registries can link to screening histories, the advantages in research and understanding of the screening impact are enormous. It would be helpful if one avoided setting up a separate mechanism for registering screening activities.
Well, this proposal to develop the screening registration to a higher level, it's emanating actually from the work package on cancer screening in the Eurocourse project, which is the project to improve cancer registration in the EU. So I think from the very beginning the idea is to work as closely as possible together. In some countries it will be the same people working in the cancer registry who are actually working on the screening register. In other countries, because it's such a big activity, they might be working next door. But I agree fully with what you're saying, work together and don't work separately.
I can say from the experience of Slovenia and Scandinavian countries that the best way is if the screening and the cancer registry are under the same roof. You have also much less difficulties with the legislation and personal data protection. So I think that this should be the aim of all the screening to be linked to the cancer registry or both together, so the evaluation is the easiest and the quickest. So we are running out of time, so I ask Dr. Ahti Antila to come here and to summarize today's session, and I thank again very much to all our today's speakers for their contributions. Thank you.